Okay.
Good morning, everyone. The Department of Neurology KAPV GMC would like to invite you to the 12th guest lecture on the topic Neurointervention in Acute Stroke. I would like to first welcome our esteemed speaker, Dr. S. VINAYAGAMANI, Consultant Neurointervention Radiologist, Madurai. Thank you, sir, for accepting our invitation. Sir, it's a pleasure to have you here, sir. Next, I would like to invite and welcome our HOD, Associate Professors, Assistant Professors of the Department of Neurology, KAPV GMC Trichy. I would also like to welcome all other esteemed faculty, consultants, fellow residents who are joining us today. Next, I would like to welcome Dr. Sridevi. She'll be speaking.
I'm very pleased and honored to welcome our guest speaker, Dr. VINAYAGAMANI sir, and he has done his MBBS Medical College and MD Radiology Maulana Medical College and DM Interventional Neuroradiology and Neuroimaging in the Sri Chitra Tirunal Institute of Trivandrum, and he has done European Board of Interventional Radiology, and also he is currently working as consultant neurointerventional radiologist in Hannah Joseph Hospital in Madurai. And has published 23 presentations and has attended 20 conferences and CME presentations, and he has awarded 13 awards, and he's also a reviewer in Neurology India and Clinical Radiology and IGRI, and his area of interest is as a neuro and vascular intervention and neuroimaging. So without further delay, please help me welcoming our speaker today.
ஒரு ஸ்பீக்கர்ல மட்டும் போட்டுக்கலாம்.
Over to you, sir.
ஒரு போன்ல மட்டும் ஸ்பீக்கர்ல.
Thank you so much, Dr. Tariq and Dr. Sridevi, for your kind introduction. So I think am I audible? So
yes, sir.
I will. Okay, thank you. So first of all, I would like to thank the head of the Department of Neurology, KAPV Trichy Medical College, Dr. Kishore sir, as well as all associate professors, faculty members of neurology team, neuro team in Trichy Medical College, all my neurology residents, as well as other general practitioners. So I'll be giving an overview about endovascular interventions in acute stroke. We'll be discussing each cases in each artery, like each variety of cases, and also in the rescue treatment. So I'll be sharing my screen. The host has disabled participants sharing. So can you change it?
Yes, I've changed, sir.
Thank you so much, Dr. Tariq. So I'll be sharing my screen. Hope it is visible. Shall we go on? If it is clearly seen.
Full like slides.
Oh, just. Is it okay now? Shall we start?
Sir, slideshow. Yeah, now it's fine.
Yeah. Okay, shall start. So I think endovascular interventions in acute stroke, acute ischemic stroke. So here, so I'm going to discuss about 4 different topics. One is how we are selecting the patient for mechanical thrombectomy or any stenting, rescue stenting in acute occlusion. Second, decision algorithm, like how we go with imaging, NIHS clinical score imaging, and then later by seeing the perfusion, etc. Then what are all the techniques available in the latest era, endovascular era of mechanical thrombectomy, and finally some challenging or special cases where if mechanical thrombectomy fails, so what we should. This is main concepts of this lecture. So I think you are very well familiarized with this guidelines and everything. So I no need to explain this current update, 2019 update of early management of acute ischemic stroke from AHA journal. So and also we are very well versed in assessing the NIHS. So basically, I just want to know, like we will be taking mechanical thrombectomy for a patient who is coming, the NIHS is above the minor stroke. We should cut off for NIHS score is 6. So mechanical thrombectomy, the NHS range for selecting a candidate for mechanical thrombectomy would be 6 to 25. So this is the ideal NHS score. So whenever there's an acute onset and it's an acute CVA, then we will calculate, then the neuro team will calculate the NHS score and they will be informing us. So the NHS will be like, if it is more than 6, itself a criteria for taking the patient. So what are all the approach in ER, where there will be a neuro team, neurologist will be there first, and then neuroradiologist will be there. So whenever we suspect acute ischemic stroke and especially aphasia is there, dominant hemisphere involvement and the large NHS, large deficit, then we have to think of large vessel occlusion. So first we have to rule out stroke mimics where we do routinely with CT, hemorrhage, or we do MRI. And also we do rule out stroke mimics like hypoglycemia, post-seizure, post-ictal changes, everything. So once we rule out stroke means we see the time of onset. So we classify the stroke into two, like onset known and onset unknown. So onset unknown is that we don't know unwitnessed stroke or wake up stroke, which you know very well about it. So onset known we classify into less than 6 hours and 6 to 24 hours. So before that, we know that we would have already assessed the patient factors, age, comorbidities, diabetic hypertension, any anticoagulant, antiplatelet, etc., or any recent surgery, everything would have assessed. You would have calculated the test time as well as the onset, everything. So if it is less than 6 hours, how is the approach? 6 to 24 hours, what would be the approach? And how is the approach in unwitnessed stroke or wake up stroke? So we'll be dealing each and everything. So first, as we know, NIH less than 6 is mostly minor stroke, and usually they'll go with thrombolysis. So the category where NIH is very high, like more than 25, and the CT aspects, that is the CT aspects is the involved area is less than 6, which is little poor, and diffusion aspects in the MRI, what we see the infarct area, if it is less area, more areas are there, then aspects will be poor. So in this case, large infarct, we have to go for coefficient to see any eloquent area is spared, any penumbra is available. So this is for large infarct. Minor stroke, there is no role for mechanical thrombectomy, it's like thrombolysis only. Whereas the ideal patient for mechanical thrombectomy would be, so as I already told, there's a disabling stroke clinically, and patient has NHS of more than 6 and less than 25. There's a clinico-radiological mismatch. That means patient has a severe aphasia and power is 0/5 and the NHS is more than 10 or 13, 14. But when you see the MRI or the CT, the infarct is very small. So if there's a significant clinico-radiological mismatch means the only small infarct is there, rest of the brain is viable, the penumbra is still available. So it is, that means the patient should need to be revascularized. Okay. So then other criteria is small core. How will you find it out the core is small or not? Core is nothing but the dead tissue or the evolved infarct. So we have to see which all is evolved. So out of 10 areas, out of the 10 areas, if 6 area is not involved, that means the aspect is good. So more than 6 means the parenchymal involvement is less only. And diffusion aspects also, like in MRI. CT aspect is in CT, diffusion weighted imaging in diffusion aspects in MRI, where there's more than 5 areas are preserved, which is not involved, then that means the patient has ideally small core and good collaterals. This we will be seeing with CT angiogram, where there's 3 phases are there. So we have to compare with the opposite side, how is the filling of distal branches. If the filling is very less or moderate or good filling as the opposite branches, then the collateral is good. If when you compare the opposite branch, the filling is less than 50%, then the collateral is poor. So this is how we will decide. So ideal patient would be a disabling stroke with NHS of 6 to 25. Clinico-radiological mismatch, small core, and good collaterals. These are all the ideal case for mechanical thrombectomy. So this is about less than 6 hours. So this criteria is the small core, good aspects, good collaterals, NHS between 6 to 25. Then we have to take for mechanical thrombectomy, irrespective of any other situations. But if it is between 6 to 24 hours, so now most of the time in the periphery or in the cities like town B cities, what happens? The patient comes a little late. So they usually come after 6 hours. So in the with the patient presents after 6 hours, like 6 to, but still the window is available till the 16 hours or 24 hours. then the best thing is what you have to do is a perfusion imaging. I don't want to confuse with this criteria and all. You just look at this slide. If it is more than 6 to 24 hours, just we have to do perfusion imaging. The perfusion imaging will be done in CT perfusion. So in the CT perfusion, we will be seeing the penumbra. Or else, if the CT perfusion is not done, because of most of the hospitals doesn't have CT perfusion, MRI is very good for a late window hours if infarct volume, where you can calculate the infarct volume by measuring the size. If the infarct volume is basically 21 cc in less than 18 years, and if there is an occlusion, take for mechanical thrombectomy. If more than 80 years, the infarct volume should be still lower. It should be less than 21 cc. Then again, we can take for mechanical thrombectomy. Without any confusion, I would like to conclude that any late presenter more than 6 hours to 24 hours, it is better to do a perfusion or MRI diffusion, and we measure the volume. If perfusion is there, okay, you can find it out. The penumbra mismatch is there, then you can take. If perfusion software is not there in your hospital, it's okay. You can do an MRI. In the MRI, you measure the infarct volume, and if the volume is approximately like less than 30 cc, okay, you can take it for mechanical thrombectomy. That means what? The infarct volume is very less, core is very less, less than 30 cc. So remaining area is available for recanalization.
Conference.
So what we can see is we can go for recanalization. This is what I have. And now we go for wake up or unwitnessed stroke. So again, wake up or unwitnessed stroke, what we do, like most of us will utilize the diffusion flare mismatch phenomena. Like if there's a tissue clock shows less than 4.5 hours, that means the diffusion, there is a lesion. I mean, the hyperintensity is there, but flare, there is no signal changes. That means we consider this as an hyperacute infarct. That is less than 4.5 hours. So we do IV altiplase. Even sometimes they use for 6 hours near this. And if it is after that, when you do a perfusion, if there's a penumbra mismatch is there and time is more than 6 hours, we go for mechanical thrombectomy. Look at stroke, and for stroke, a patient presenting with onset of more than 6 hours, the best imaging is MRI or perfusion. If you have CT perfusion, go for CT perfusion. If you have MRI, just calculate the infarct volume and the collaterals, and you go ahead according to it. So this is the summary of the flowchart which I have already mentioned to you, like how to select the candidate, how to decide, how to follow the algorithm and decide the patient for mechanical thrombectomy. So next we will go to the summary. In nutshell, like what are all the eligibility criteria according to our ASA guidelines for mechanical thrombectomy. So we know pediatric, their guidelines has never been imposed, especially the ASA guidelines is only for more than 18 years according to, but there are a lot of pediatric case series other where we do mechanical thrombectomy for pediatric cases, but according to the guidelines it is only for adults more than 18 years we do, and age more than 90 years you have to see that any comorbidity is there, you have to see any life expectancy, quality of life, etc., etc. Then we have to decide. Then pre-stroke MRS is very important because we have to give functional independency on thrombectomy. So we have to see the MRS score more than 1 or 0 to 1 or how it is there. So then NIHS. So as I already told, it is within 25. CT aspect should be good, more than 6. And there should be definitely, this is the very important thing, there should be the presence of large vessel occlusion. Large vessel occlusion means it should be ICA, MCA. There is no, currently there is no guidelines from ASA for doing a mechanical thrombectomy for AC occlusion or PC occlusion. Whether it is a posterior cerebral or anterior cerebral, there is no guidance. It is only for basilar, internal carotid artery and middle cerebral artery, M1 MCA. Whereas the M2 MCA, dominant M2 MCA involving the electron cortex, it is still beneficial, but it is not according to the guidelines. So then we'll go to puncture time, ictus to groin time. So if it is less than 6 hours indicated, 6 to 16 hours, then you have to go for diffusion or Dawn criteria or diffuse criteria. So we will go to the techniques of endovascular thrombectomy. So basically, what you can see is so many techniques are available for removing clot from the brain vessel. So the most common technique is stent retriever thrombectomy, and second thing is aspiration thrombectomy or ADA, then Solumbra technique, cover assisted technique and dual stent retriever. So here the most commonly used technique is top three. First is stent retriever. We pass the stent retriever and we will remove the clot. Second is aspiration. We'll aspirate the clot. And third is Solumbra. Solumbra is nothing but the combination of stent retriever and aspiration thrombectomy technique. Dual stent retriever is like in a resistant clot, if it is not able to extract a clot, then we pass two stent retrievers in the single vessel and then we will be deploying the two stent and we will be pulling out the stent retriever. Okay, so as I already told, these are the various EVT techniques. First, I will just tell brief some idea about stent retriever. Stent retrievers are nothing but a or nickel or platinum made woven stent like structure, which is very flexible and pliable, also very conformable. So various stent retrievers are available in the markets: Solitaire, Mindframe, TrevoPro, Preset, and Eric, Trigger Retriever, Embotrap, etc. So nowadays, most commonly used stent retriever is Solitaire, Preset, and Embotrap. So these are commonly used stent retriever. So if you see this image, I think you can able to observe. This is the vessel. We are passing the stent retriever into the clot. We are first. This is not. It is actually. It is opened now in this image. Basically, we will be passing the stent retriever through the clot over a microcatheter, and we will be opening the stent retriever. We will be deploying the stent retriever. When the stent opens, it will come. The struts of the stents will enmesh the clot. It will just attach to the clot, and then it will get enmeshed. After a dwell time of 5 to 6 minutes, it will get attached. So when you pull out the stent, the clot will come along with the stent retriever. Then we will open the vessel. So this is the way we remove this. We remove the clot using stent retriever technique. Aspiration thrombectomy is simple like a peripheral or a cardiac cases where you do a coronary aspiration, where you keep a guide catheter here close to the clot, and then you can see this is the vessel. We'll keep a guide catheter. We take a reperfusion catheter, aspiration catheter, which is in the white. This aspiration catheter will be kept at the edge of the clot. Once it is kept at the edge of the clot, we will be starting the vacuum pump with the negative pressure, and once the vacuum pump sucks the clot, slowly the clot will get aspirated into the catheter, aspiration catheter, or because of the negative suction, it will get attached to the tip of the aspiration catheter and then it will be pitched off. So this is aspiration thrombectomy technique. And these are the various aspiration thrombectomy catheters are available with the pump. You can see the most commonly used is A68. This will be very soft and pliable. Sophia also. Both are very soft and pliable, commonly used. CAT6 is also available. So all top three commonly used aspiration catheters is A68, Sophia, and CAT6. So they're very soft and pliable. Go and just it will engulf the clot. Once it gets engulfed, once we know that it is in contact with the clot or the thrombus, we will be switching on the aspiration system. You can see this is the aspiration system or the machine. Where once you switch it off, they will start exerting a continuous negative pressure, and then it will suck the thrombus inside the canister. So once the thrombus is slowly enter into the canister, then there will be free blood flow. That indicates that the clot has been completely removed. So Solumbra technique is simple. Like as I already mentioned about stent retriever and the Solumbra, we will be passing the stent and then we will be passing the aspiration catheter together. So first we will be deploying the stent across the clot and then we will be passing the catheter over the stent retriever and we will be pulling both together as a unit. So this is most effective way of removing the clot. Especially if you're suspecting or anticipating that this will be having a resistant recanalization or refractory cases, refractory occlusions, the best technique would be Solumbra. And we are mostly using Solumbra technique because once you use this technique, the first pass recanalization rate is very high. So if you are taking both together and if you are removing the clot, 90% the clot will be removed. So that is the most important advantage of this technique. But exceptions are there, like atherosclerotic occlusions where there's a stenotic plaque is there underlying, then even Solumbra technique will not work. We have to go for rescue stenting or angioplasty. So this is the summary of the most common technique I am just describing. So many techniques are the dual stent retriever, etc., but this is commonly now performed in India. So aspiration, stent retriever, and Solumbra. This is a combination of both. You can see here the aspiration catheter. Here you can see the stent retriever. Here we both the aspiration catheter and stent retriever. So that is the Solumbra technique. So we'll go to the cases for a better understanding and for better interpretation of the this topic, neurointervention acute stroke. So I'll be giving example of different cases for understanding. So first will be take a young patient, it's a young female presented with acute onset altered sensorium and facial deviation. The first case is just a mid-cerebral artery thrombectomy. So slurring of speech is the, so when we calculated NHS it was 60. So NHS is 60, it is very clear it is an large vessel stroke and it is an indication for mechanical thrombectomy. So immediately what we do, we just after the assessing the NIHS, we just calculated. We know the test time is 5 p.m. But the onset, like patient came after 5 hours. So even 5 hours, that means immediately we have to do an MRI image. Even though CT is there, the gold standard imaging for evaluating acute stroke for thrombolysis or for thrombectomy or whatsoever, MRI is the best. MRI stroke protocol is the best or the gold standard investigation to select the patient for any treatment like thrombolysis or thrombectomy. So the patient came after 5 hours. NHS is 16, young patient. So we did an MRI. MRI you can see insula, temporal lobe, putamen is involved. So here if you see this is insula is there and M3 is there, M2 is involved as well as putamen. So aspects is 5 by 10, borderline aspects. We have measured the infarct core. But here the infarct core is little high, 48 cc. But the patient is a young patient and came within window period. So there is no point in measuring the infarct core. So directly we see there is a diffusion flare mismatch is there. A patient is having a less or small infarct volume or core and good moderate aspects. So without any doubt, we took the patient for endovascular thrombectomy. So we know MRI, there will be an MC occlusion. You can see like here you can see there is an infarct and then you can see there is an MC occlusion. And what we did is, I think you can see the first one, you can see there is a, you can see the cutoff here. So this is the collaterals, you can see the cutoff here. So there's a straight cutoff of MCA. So here is the clot. So after the angiogram, we did a mechanical thrombectomy. You can see the stent is deployed across the middle cerebral artery. Across the middle cerebral artery, that means the stent is deployed across the clot, so that the struts will enmesh with the clot. And next, you can see in this image, I hope so, like you can see there is a complete opening. So you can see there is a complete opening of the MCA branches with forward flow in the superior and inferior tension. So this is the simple mechanical thrombectomy. We took 45 minutes to open the vessel and patient improved a lot. And you can see this is the clot which we have extracted from this young female. And you can see this is the pre-procedure cutoff and this is the post-procedure opening of the vessel. You can see this is the cutoff. And you can see here's the opening. The importance is young stroke, we have done a workup for atrial fibrillation or whatever cardiac causes or hypercoagulable states, mutations, everything, etc. Everything came up negative. But finally, we found it out. We did a TEE in transesophageal echocardiogram. We found that there's a paradoxical emboli, and then they got prepared for it also. So this is basically a young embolic stroke causing mechanical, causing MC occlusion. So we did an MCA thrombectomy, and finally patient is doing very well. Here you can see the follow-up. So usually we do the follow-up with the outcome will be evaluated by this MRS score. We know MRS 0 means no symptom. So MRS 1 is non-significant disability, MRS 2 is slight disability, moderate disability, etc. etc. So this patient at discharge, power is 4 by 5, improved very well, but she has still had a slurring of speech. So MRS is still. When we do a 3 months follow-up, the MRS is 0. She doesn't have any residual effect. Now she got married and she is as a bank worker also. She is working. She is coming for regular follow-up, but she is doing pretty well. So we'll go to the second case. This is the basilar thrombectomy. So we have completed the MCA thrombectomy. Basilar thrombectomy is a 56-year male presented with sudden onset of left side weakness. So since it's a basilar, patient had a low GCS. The initial GCS was 60 only, intubated. So we know it's a clinically it's a post-circulation stroke, and patient has lot of comorbidities already on dual antiplatelets for aspirin and clopidogrel, and diabetes, hypertension, this everything is night. Patient came at 1:30 p.m. So we did an MRI and we can see there is a PONS involvement, hemipontine infarct, cerebellar infarct. Luckily, you can see the patient GCS is 60, but infarct volume is very less, as well as the MR aspects is 7 by 10. It's a good aspect. So when you see the MR angiogram, you can see there is a complete cutoff of basilar. There is no filling of basilar artery. Bilateral vertebral also there is no filling. So what we did a mechanical thrombectomy. So you can see there is a slow flow of right vertebral. You can see here. You can see the slow flow of right vertebral. Basilar is not formed. You can see here the pica. It ends at the pica. At the pica there is a absent flow. I mean the contrast stops at the pica. So and also let's so it's a vertebrobasilar occlusion. So what we did again, Solumbra technique. What we did is we just deployed the stent retriever completely. We deployed the stent retriever completely, and then we have passed the aspiration catheter along with the stent retriever. You can see here there's a aspiration catheter as well as the stent retriever. Both are there. So Solumbra technique we did, and then we recanalized the patient. You can see here complete recanalization. But we can see so much disease here because we have opened the basilar artery, but you can see the basilar artery, it has diffuse atherosclerotic stenosis with stenosis is there. But we didn't do any stenting because you can see the flow is very good. Here there is a mid basilar, there is some 50% stenosis, but in acute condition, if there is reduced forward flow and residual stenosis of more than 50%, we have to stent it. Or else no need. You can see here there's a good flow, so that indicates that there is a good perfusion. So that doesn't need any stenting. So here you can see the aspiration catheter stent retriever. You can see a long clot. This is because it's a lengthy clot because it is from the basilar PCA to vertebral artery. So this is such a lengthy clot we have removed with the Solumbra technique and then improve. You can see patient discharged after 12 days, follow up after 1 month. Residual left hemiparesis power is just 4 by 5. It improved. Other functions are preserved. MRS is 2 after 1 month. Okay, so the importance of mechanical thrombectomy in this patient is first is life-saving because we prevented the progression of infarct to the brainstem as well as other area. Second thing, it gradually improved the power as well as the patient MRS is from it improved to 2. That is, he's slightly disabled, but however he can able to do his activities independently. The reason for this is the patient had a dual antiplatelet and still patient had a stroke. That means it is a resistant clopidogrel or resistant stroke. So what we did is we changed the antiplatelet to higher antiplatelets. We started prasugrel, ticagrelor, so that patient was not having a progressive disease unfollowed. The patient came after 3 months. We did a repeat angio where there is the same disease. There is no progression. So with the Brilinta, he is doing very well, and there is no need for stenting also in this patient. So then third case would be right MCA stenting. So this is a young 71-year female presented with recurrent TAA for past 3 days on dual antiplatelets, diabetic hypertension. Presentation of GCs was 15 by 15. So the she said that she has some TAA for past 2 days. Warning symptoms were there. So when she got admitted in the ER, her power was 5 by 5. So we deferred mechanical. We said that patient has NIHs of just 1 or 2, no need for mechanical. But 1 hour later, patient GCs also got worsened, like 12 by 5, and power is also worsened 1 by 5, and there's slurring of speech. What does this indicates? This indicates that it's a stroke in evolution. So you know very well, this is a stroke in evolution, and again the NIHs rose to 12, I think. So we did an MRI. There is a mismatch, clinical radiological mismatch. You can see it's a very small infarct, but see the NIHs, it is 13 or 14, and patient had a a drop in GCS with loss of power, even hemiplegia, slurring of speech, etc. So right side you can see there's a putaminal audit is also mildly involved. But this is stroke in evolution. MR aspects you can see putamen, caudate, and basal ganglia involved. So we aspect is very good. That means the patient have to be taken for mechanical, and we have removed the clot. So you can see there's an MC occlusion. So after opening the clot, what we found is there's a stenosis. You can see here. We can see there is a stenosis here in the mid-M1MC. And because of that, we can see there is slow filling of the hemisphere. That means the cerebrovascular reserve is inadequate. The collaterals is very poor. So the patient have to be stented because patient doesn't have a good collateral. So we have to improve the forward flow. So what we did is we did an angioplasty initially. we have opened the vessel, and you can see here, after angioplasty also, there is a stenosis. You see this image, still there is a stenosis. So what we did, we have stented that. You can see the stent across the stenosis, and you can see the stent in situ here, the arrow marks. So after the stenting, you can see the good robust flow. So you can see the comparison. So pre-stenting, you can see the stenotic lesion. You can see the post-mechanical, there is a stenotic lesion. So finally we stented because patient have to be established a good antegrade flow because the collaterals are not that good. Okay. So next we see the CT. We can see that stent is there in situ with good patency. So now we'll go for a fourth case, the bachelor stenting. Patient 39-year smoker, drowsy, unresponsive. GCS is 9 by 50, came within 8 hours. So within 8 hours, low GCS, it is very clear it's a post-circulation stroke. Multiple cerebellar infarcts are there, midbrain infarcts are there. Even you can see the left thalamus is there, medulla is there. So again, the infarct volume is okay. It's not very big. It's moderate infarct volume, and there is basilar occlusion, complete basilar occlusion. So we first have to prevent infarct progression, and then for that we have to do a mechanical thrombectomy, and the GCS is approximately 9. So patient with this clinico-radiological situation, the patient requires mechanical thrombectomy. So again, it is very obvious that patient had a what you can see. You can see here is an occlusion of the left vertebral artery. You can see there's occlusion of basilar. So then you can see we have opened the vessel. We plastied the vertebral and basilar junction. Balloon angioplasty of the vertebral artery and ectobasilar junction. Then after the plasty, there's a complete reperfusion. So here you can see, after that we waited for 20 minutes because if there's an underlying atherosclerotic stenosis, you have to do a plasty and then you have to wait for 20 minutes. If you see here, the stenosis is still there. You can see very aggressive stenosis, this area. So what we did, did a plasty and then we stented. We deployed the stent and then we opened. So post stenting, the patient is doing very well. We can see this is the occlusion. This is the post mechanical thrombectomy. This is the angioplasty. So this is the restenosis. This restenosis occurred after 20 minutes, where you can see there is a severe stenotic lesions here and here. So we did the plasty. So after the plasty and stenting, the patient improved. So we can see like this patient came after 2 years. Patient is doing very well, functionally improved. His MRS is just 0. There is no residual defect. He responded well to the neuro rehabilitative therapy and all. So you can see the stent in situ with the vertebrobasilar junction. So patient is doing very well, and it is on single antiplatelet because of the stent. So we put on single antiplatelet, and patient is doing very well after 2 years. So this is the last case where you can see there is a tandem occlusion. Sometimes what happens, you will have both occlusion of both MCA as well as ICA. So this is one of the case where there is a 48-year male presented with the NHS of 15, left hemiparesis and facial palsy, came after 15 hours. So tissue window is there because if you see the infarct volume, it is very less than 25 ml only. So you can see the volume of the infarct is very less, 25 ml, and patient had NHS of 15. So we went ahead with MR angiogram, which shows complete occlusion of right ICA as well as the MCA. So after the thrombectomy, what you can see here, we have opened the right MC, but see the flow. The flow is very slow. It's very sluggish. It's just inadequate. What the reason is carotid. You can see such a severe stenotic lesion in the carotid artery, especially the proximal. This is the bifurcation. You can see the proximal carotid artery, severe stenosis, ulcerative plaque is there. So unless you address this plaque, unless you address this plaque, there won't be any improvement in the cerebral circulation because there will be again a reocclusion. So what we have to do is, we have to do an angioplasty initially. So you can see the plaque, irregular plaque. So we did a balloon across the lesion. With that, after the ballooning, we can see there's persistent stenosis. So what we did, we deployed a stent, carotid stent. So you can see the stent staking the stenosis. So after the plastic, we did a post angioplasty of the stent. The stent is completely open. So the patient had a very good flow. You can see here. So we have deployed the stent, and we did plastic. We are doing the plastic for the stent also. So plastic the stent, and you can see the flow. The flow is very good here. So you can see the flow is very good, and we have corrected the stents. So this patient had a NHS drop from 4. See, from 15, the NHS has been dropped to 4. And immediate post-procedure MRS is 3, and 3-month follow-up MRS is 1. He is on dual antiplatelets because of the stenting, and you can see there is a neurological improvement. And this is the Doppler of the carotid stent. You can see there is a good forward flow. There is no instant thrombosis. There is no restenosis of the stent. This is a follow-up Doppler we have done after 3 months, which is also fine. So this is like a case of both IC and MC occlusion, where sometimes you may have to stent the carotid artery for maintaining a good forward flow. So this is an example for that case. So I think to conclude, so regarding the mechanical thrombectomy, the take-home message which I want to emphasize is, first thing is, for any interventions, first there will be careful selection of patients for good outcome. So the careful selection is very important because it is multimodality team approach: neurology, neuroradiology, interventional neuroradiology, neurosurgery. So there should be a team approach, and so that we can select a patient very carefully. And second thing is techniques. You can't rely on one technique. You have to have a backup. You have to have multiple plan A, plan B, plan C. Just we having a stent retriever, we do a thrombectomy, is not going to work out. We have to keep a stent as a backup. We have to keep a balloon as a backup. So we have various techniques, and different techniques are there. So it depends on the operator and his experience, his or her experience. So different techniques, the need for stenting, angioplasty, everything varies case to case basis, because everything will be decided on table. Only the mechanical thrombectomy will be decided off table. But after taking the patient to the mechanical thrombectomy, stenting is needed or angioplasty is needed, whatever will be decided on case to case basis according to the on table findings. And finally, there should be a structured stroke care system. That is, a comprehensive stroke care center should be there. There should be rapid assess. A rapid ER, neurology, neuroradiology, and neurosurgery team should be there for doing all kind of this comprehensive interventions. So I thank you everyone for this opportunity. I'll just give again once again I thank the Department of Neurology for inviting me for this guest lecture. I hope you would have enjoyed this session. You can ask me if there is any questions.
Thank you, sir.
Dr. Elimi,
Thank you, sir, for the excellent
thank you.
talk. Um,
Any questions? Dr. Elimi, very nice talk actually.
Thank you, sir.
It's
Thank you
really
so
an
much.
the students.
Sir, in the chat box, question question
Yeah,
by
just
Dr. Vipin Patel. Please tell about the antiplatelets post stenting, the duration, the dose, and the choice of.
Basically, what we do is, if we stent the patient, we have to see whether the patient is already on old antiplatelets. If already on clopidogrel and aspirin and the patient is having an occlusion, that means probably he is resistant to one of the antiplatelets, especially clopidogrel. Resistance is very common. So in that case, you have to put a newer antiplatelet like ticagrelor. So we have to put 2 antiplatelets. We have to load it on the table during the mechanical thrombectomy if you are planning for stenting, and then we have to continue dual antiplatelets for 6 months, and then we have to do an imaging. We have to see any restenosis. If there is no restenosis, we can stop one antiplatelet, and the patient have to be continued with lifelong single antiplatelet for the stent.
So next question by Dr. Ramesh Kumar. Tell something about embolic stroke and thrombectomy and thrombolysis.
Embolic stroke, basically it is a fresh red clot, so it is easy to retrieve. It's basically an RBC clot mostly from the cardiac or some proximal arteries. So it will again the embolic stroke would be treated as similar as atherosclerotic stroke in terms of thrombolysis as well as in thrombectomy. But what happens in thrombectomy, atherosclerotic stroke will have a little bad prognosis because underlying stenosis is there, you have to stent it, you have to balloon it, etc. But usually embolic stroke carries good prognosis because it is easy to open and easy to do first pass recanalization. So it is easy. Basically, you can finish embolic stroke within 1 hour. Once you puncture, we can retrieve by within 45 minutes. There won't be underlying stenosis because it will be most common in young patients, no? So there won't be any disease target. So embolic stroke has a better prognosis and better angiographic results also.
So next question by Dr. Dilip Maheshwari. None of the patients underwent perfusion images. So what is the role of such images?
As I already told you now, if you don't have any perfusion images, no problem. Because for late presenter, 6 to 24 hours, you have a down criteria and diffuse criteria. Where if you don't have CT perfusion, you can measure MRI. So this images of MRI, MRI images showing the infarct volume. So we have to develop an ADC map. ADC map, you measure the infarct volume. Even MRI, you have ADC map, and then if you measure infarct volume, that is more than enough. No need to go for CT perfusion. If it is not available, MRI is enough for you to do all kind of interventions.
So question by Dr. Natarajan. Safety of intraarterial fibrinolytics. Safety of
intraarterial, basically what we do is intraarterial fibrinolytics we generally won't give for mechanical thrombectomy. There's a chance of bleeding, but this is not like my opinion. We go according to the guidelines. So in 2015, I think after 2015, nobody is using intraarterial fibrinolytics, IV altiplase or something into the artery. Rather, what they are doing after IV thrombolysis, they give intraarterial tirofiban for atherosclerotic stroke. Because once you disturb the plaque, it will be very sticky and the platelets will get formed. So they give tirofiban for that. So still now in the current guidelines, there is no the ASA guidelines. They are not advising to use intraarterial fibrinolytics. Again, because of the safety concerns and risk of intraparenchymal hemorrhage. So we are not using it.
Sir, next question by our HOD, Dr. Kishore sir. Can you tell us about the cost of the procedures, sir?
Yeah. So basically, the cost is it is about 3.5 lakhs. Stent retriever, catheter, everything. 3.5 lakhs to 4 lakhs the cost of the procedure.
Sir, next question by Dr. Ramesh Kumar. Should we always thrombolyze before thrombectomies?
So that is a good question. Basically, what we can do is always thrombolysis is very important. Recent trial shows. We have to shift the patient to cath lab, we have to puncture, we have to open, so many things we have to do, no? So this will be a bridging effect will be there with the thrombolysis. Only thing is one situation where if you are planning to do stenting, if you are suspecting atherosclerotic stroke and you have to do stent, when you do stenting, you have to give a lot of antiplatelets, you have to give tirofiban. In that case, thrombolysis previous thrombolysis will have recent thrombolysis will have a risk of hemorrhage. So in that case only we have to be very careful. Otherwise, most of the case, it is better to thrombolyze and then to go for thrombectomy if the patient presented within 4.5 hours. So as according to the guidance, the patient presented within 4.5 hours, you can thrombolyze and then send the patient for cath. So that it will be a bridging, it has a bridging effect also. So there is an trials, RCT trials were showing, comparing the thrombectomy alone, thrombolysis plus thrombectomy. There is no outcome difference they were telling. But still, so many series were telling that thrombolysis will act as a bridging effect for thrombectomy. So you can do a thrombolysis and then you can go for a thrombectomy. What we do in our center is our same only. We thrombolyze and then we take for thrombectomy most of the time.
So next question, can we thrombolyze for venous thrombosis?
Yeah. Venous thrombosis only thing again according to ASA guidance only. If the patient is on anticoagulant but GCS is dropping down, refractory to medical treatment, GCS is dropping, then we can do intraarterially, we can keep altiplase and we can try thrombolysis intraarterially. And second thing is we can do mechanical thrombectomy also. But this is only for endoscopy, only for resistant or refractory cases. Especially if the patient is having a drop in GCS or not responding to medical treatment for 2 to 3 days in a cerebral venous thrombosis and the clot load is high, then we can do it.
So next question.
How much we should wait for thrombolysis effect before thrombus? No. See, the guidelines is if there's a large vessel occlusion, After thrombolysis, you no need to wait. You have to send for thrombectomy. You no need to wait. Because you should not assess the effect of thrombolysis by stopping the patient shifting to cath lab. After the, if the patient is coming within 6 hours or within 4.5 hours, you large vessel occlusion is done, you thrombolyze and shift the patient for cath lab for mechanical thrombectomy. You should not wait for the response of thrombolysis.
So next question by Dr. Ananthi, like criteria to decide on thrombectomies.
Most of the complications will be puncture site. Sometimes there will be puncture site hematoma, which will be managed conservatively. One complication is very dreaded complication. Sometimes moderate sized infarct and patient have already thrombolyzed because the patient have come before 4.5 hours. In that case, when you do stenting and if you put a lot of antiplatelets, that's a chance of parenchymal hemorrhage or hemorrhagic transformation. But you should be very careful. That's what the balance between stenting and the simple thrombectomy is very important. For not all the cases, you cannot stent. You have to see the infarct. If there's a risk of hemorrhagic transformation or a risk of bleeding is high, you should not stent the patient. So the most common, mostly the dreaded complication which we see is hemorrhagic transformation. Otherwise, mostly you don't have any. I mean, maybe sometimes a non-targeted embolic infarct, but that will be resolved. That will be like that is not life-threatening.
So next question, like are the catheter stents?
Yeah, because it is mostly from Europe, US, and UK. These are all imported catheters, no neuro catheters. So it is not, there is no own manufacture from Indian company. So most are from abroad. So the costs are very high, and there is no insurance also for mechanical thrombectomy. Like for cardiac, you have insurance, no. For coronary interventions, for mechanical, there is no risk. That's the reason.
Thank you, sir. Any more questions? So, sir, what is the role of heparin in diffusion flare? One second, sir.
See, heparin, the problem, heparin is for dissection and for embolic stroke, heparin has a very good role. But for atherosclerotic stroke, there is no role for heparin except for DVT prophylaxis. So you can use it if it is a dissection or if it is a CVT or kind of thing. But for atherosclerotic stroke, heparin will not work. Only for DVT prophylaxis it will be used. So heparin is not effective for thrombolysis, thrombectomy. Heparin is not an adjunct. Okay.
Thank you, sir.
Thank you so much for your patient listening and giving me an opportunity to discuss my experience on acute stroke interventions.
Sir, I would like to invite Dr. Ilakya to deliver the vote of thanks.
Yeah.
Morning, sir.
Good.
I would like to thank my HOD sir, Dr. Kishore, for organizing this online meeting, which was a very good academic feast for all of us. Thank you, sir. I would like to thank Dr. Vinayagamani sir for his valuable time and wonderful lecture, which was an eye-opener for all of us. Thank you, sir. Finally, I would like to extend my gratitude to the faculties of Neurology Department of KAPV GMC for their role in this meeting. Thank you, dear teachers. I conclude by thanking all the attendees of this online meet for your valuable presence today and meeting a memorable one. Thank you, all of you. Thanks.
Thank you so much.
Well done.
Yes.
Thank you.
Thank you, sir.